Okay. Gabriel Kubota had as supervisor of his PhD, Professor Daniel Ciampi, but Dr. Daniel Ciampi is not available today. Then I will replace him. We have a board evaluate with Dr. Ricardo Iglesio, that it's a functional neurosurgeon from University of São Paulo. Professor Ida Fortini, it's a neurologist specialized in pain management, patients with pain, and Professor Javier Mose. It's French, and then Xavier or
Xavier. I'll call him. Do you prefer to
Professor?
Xavier. In French, we pronounce Xavier Moisset.
Okay, Xavier Moisset, from University de Clermont-Ferrand.
Well said.
Okay. Pessoal da transmissão, já está aberto a transmissão para o YouTube?
Já está transmitindo já. Pode começar.
Okay. After his defense, we will have discussion with board evaluate, and then I will present again the member of this board, Dr. Kubota.
Thank you, Professor Wellington. Good morning. Thank you for being here with me today. First of all, I'd like to thank your attendance, especially the members of the examination board, Dr. Ida, Dr. Ricardo, Professor Wellington Paiva, and special thanks to Professor Xavier, who's watching us online from another time zone. Thank you for being here today. It's an honor to have you with me in this very important moment of my academic career. Today, I'll be presenting my PhD project. It's called Correlations Between Non-Invasive Estimations of Intracranial Pressure, Clinical Parameters, and Lumbar Puncture Opening Pressure among Outpatient Subjects. This project was supervised by Professor Daniel, who unfortunately couldn't be here with us today, but sends his regards anyway. Well, this is the outline of what we're going to be discussing today. I'll start giving you a brief overview of the field and the questions that led to the research at hand. Well, as you all know, intracranial pressure is a valuable parameter for diagnosis, monitoring, and treatment of a series of very relevant outpatient, clinically relevant neurological and neurosurgical patient conditions. Okay. And so it's very important, and ranging from secondary chronic headaches, for example, idiopathic intracranial hypertension, hydrocephalus, or for example, chronic CNS infectious diseases. But the gold standard way to measure it nowadays is still lumbar puncture, which is a very important procedure, but it's not perfect. It's often painful, it's invasive, it may not be done in some groups of patients, for example, patients undergoing anticoagulation, which is ever more frequent in the past few decades. They cannot undergo this procedure. The measurement is not perfect, as it's possible to overestimate the intracranial pressure in case the patients get anxious and do a Valsalva maneuver, or underestimate it if there is an obscure spinal canal block, and it's not without complications, ranging from very severe, although fortunately infrequent ones, such as infection, bleeding, from to more common complications, although less severe, such as post-lumbar puncture headache, which may happen in up to 9% of patients, even when using the automatic needle, which reduces the risk of this complication. Although self-limiting, this may be very bothersome for the patient. Now, to top that off, the diagnosis yield of the procedure is not high. It's moderate at best when looking at the settings where in the outpatient settings, in outpatient clinic, we choose to do this procedure. The diagnostic yield goes from 30% for hydrocephalus to around 50% for idiopathic intracranial hypertension. Therefore, it would be very appealing if we had a screening test that could help us identify the patient who would have the highest probability of an altered examination, an altered procedure, and therefore providing a higher diagnostic yield, reducing healthcare-related costs, and reducing procedural complications. Now, how to do that? One way out, the avenue we pursued in this research, comes from this device here, which was developed by Professor Sérgio Mascarenhas, who worked actually at the São Carlos Physics Institute. Unfortunately, he passed away a few years ago, but he developed actually a sensor, cranial extensometer, that is able to perceive very small changes to the cranial surface that are induced by the variations of the intracranial pressure throughout the time. These variations are called cardiac-gated intracranial pressure waveforms, and they result from the pulsation of the intracranial vessels. Now, this instrument can censor and can depict the morphological characteristics of the waveform with reasonable accuracy, although it cannot measure exactly the value of the intracranial pressure. So it's possible to say if it is altered or if it is probably normal. We can do that because from earlier researches with traditional invasive intracranial pressure measurements, we know that this type of wave has a very typical morphology, which is three-peaked morphology. The biological mechanisms underlying each of these peaks are not completely understood, but we assume that the first peak, called percussion peak, results from the pulsation of the choroid plexus and large intracranial vessels, and therefore is closely correlated with the systolic blood pressure peak. The second peak, the tidal peak, is resulting from the rebound of brain vessels pulsations and is closely related to the cerebral artery blood volume peak and craniospinal compliance. And the third peak, the dicrotic peak, results from the retrograde venous pulse of the jugular against the cortical veins and is closely related to the venous blood outflow from the cranial space. Now, in healthy conditions, usually the amplitude of the peak 1 is higher than peak 2 and peak 3, but as you have, as intracranial hypertension occurs and the craniospinal compliance is reduced, then the tidal peak becomes dominant, the amplitude of P2 goes higher than P1, and you can express that through a parameter called P2 divided by P1. If it is under 1, it is probably normal. If it is beyond usually 1.2, it is probably abnormal. Now, this procedure, this device has been tested before in some studies. This is a publication of Neurocritical Care this year. It summarizes the studies published for this device, and they all seem to yield very promising results. As you can see here, the sensitivity goes from 60 to 93%, the specificity from 60 to 69%. That is compared with the traditional invasive intracranial measurement devices. And the accuracy is also very acceptable. Usually we consider that in an area under the ROC curve over 0.7 to be acceptable. So it ranges from 0.786 to 0.9, very promising results. However, all these studies were conducted in the setting of the acute brain injury patient, so in the critically ill. Can we really translate this evidence to the outpatient setting? Well, the only study which came close to attempting to approach this question is this one. It was published in 2017. It tried to see whether the instrument, this approach, could identify children with acute intracranial hypertension due to decompensated hydrocephalus from healthy children, surgically treated hydrocephalus and compensated hydrocephalus. It found that the method could do that with high sensitivity and high specificity. However, again, it is a study that only included children. It did not compare with traditional invasive methods, so we aren't sure if there was actually intracranial hypertension, but the diagnosis was basically done on clinical grounds. And although it was an outpatient setting, the condition studied here is reasonably acute / subacute, so it's not a chronic intracranial hypertension. So it's not necessarily these results can translate to what we have in the clinical neurology and neurosurgical outpatient setting. Therefore, we set out to do this research, And the main objective of this research is to explore, it's an exploratory study, the accuracy of parameters obtained by a non-invasive waveform assessment approach in detecting intracranial hypertension in a real-world outpatient population. We tried to do an exploratory study, but with a pragmatic view, trying to sample what would be a real-world sample of patients who would be referred for this procedure. Now, we're doing that, we used a very simple design. We actually enrolled patients who were referred for routine lumbar puncture by their attending physicians. These patients were screened, and if found eligible, they were initially assessed clinically, and then they underwent a baseline non-invasive waveform assessment in the supine position. After that, they were divided into 3 groups sequentially. The largest of them, Group L, where they underwent lumbar puncture and then another non-invasive waveform assessment in the supine position. The second group, Group C, Group S, underwent a second non-invasive assessment in the sitting position and again a lumbar puncture, and Group V underwent a non-invasive assessment during controlled Valsalva maneuver in the supine position and again lumbar puncture. Now, as you can see here, in this part of the study, we attempted to do ICP raising and lowering maneuvers to assess whether these would change the morphology of the waveform, if this would add to the accuracy of the method. So Group L and Group S would be ICP lowering maneuver and Group B ICP raising maneuver. Group L, we chose Group L to be the highest, the largest one, since it is more controlled than the sitting position, and we know how low the pressure went after the LP. Our eligibility criteria were quite wide. Again, we wanted to do a very pragmatic study, so it's all adults being referred for the procedure. We excluded patients unable to provide informed consent or who had any contraindication either to do the lumbar puncture or technical impossibility to do the assessment. For example, patients with significant skull bone defect or history of non-surgically corrected meningeal cell, meningoencephalocell cell, or any technical impossibility for measuring opening LP pressure. For subjects from Group V specifically, we considered contraindications for prolonged Valsalva maneuver. Now, this is a very original study. So far, it's the first to address this question. And we didn't have any other studies to base or sample size calculation. So we used a convenient sample of, we estimated 130 patients, which were divided into 3 groups with a ratio of 2 to 1 to 1. We took in consideration that the largest study controlled by a standard invasive method in the setting of the acute brain injury enrolled 72 patients. The largest outpatient study, which I showed you before, included 56 children. In these studies, the proportion of subjects with intracranial hypertension was between 8 to 18%, and expected proportion of our sample who would have intracranial hypertension based on our clinical experience would be around 1/4 of them. The patients underwent, once selected and once they accepted to participate, they underwent an initial assessment based on a structured interview, obtaining general demographics data, reasons for LP and CSF analysis, medical history, previous neurosurgery and CSF shunting, and current medications, and a brief physical examination. Then they were positioned either on the supine position or in the upright sitting position, and then the device was placed in the left temporal region, just over or just above the pinna. It was held firmly in place by a rubber band and connected through an adapter module to a monitor, which allowed us to observe on real time the signal that was being captured by the sensor. Now, we could do very small adjustments to the rubber band strain or to the gain of the adapter module to get a better signal. But after that, the patient was instructed to remain very quiet, and a 5-minute monitorization period ensued. After this 5-minute monitorization, the signal was recorded, and this raw signal was processed into an average waveform that depicts the average behavior of the waveform throughout the 5-minute monitorization period. Outliers over 2 standard deviations were excluded from this calculation. As you can see here, the full line is the average, and the distance between the hashed line represents the 95% confidence interval of the variation at each time point of the graph. Now, for the Valsalva procedure, we used a procedure that was published before. Basically, it's a very simple one. We connected an open-ended syringe, 10 ml syringe, with a manometer and instructed the patient, once in the supine position, to blow into the barrel of the syringe and to keep the pointer of the manometer between 20 to 30 millimeters of mercury for at least 20 seconds. For this procedure, the waveform was calculated based on the signal obtained only during the Valsalva maneuver and not throughout 5 minutes. Now, these are the outcomes. The most important outcome of our study is the intracranial hypertension, which was defined as an LP opening pressure over 25. Abnormal chemocytology, a CSF cell count over 4, or a CSF protein level over 40, or an abnormal LP test, which is either intracranial hypertension and or abnormal chemocytology. Now, after that, once this waveform was obtained, researchers blinded to the LP results extracted the parameters we use for our analysis, both raw parameters, which is the amplitude to each one of the peaks I told you before, the latencies, the time between the beginning of the waveform to the point of the maximum amplitude of each one of the peaks, the total latency of the waveform, the latency to peak, which is the latency to the highest amplitude point of the waveform, irrespective of which peak it belongs to, and also the lowest, it's not in the graph here, in the lowest point between P1 and P2. We also calculated the waveform area divided by the total latency, P2/P1 parameter, and the slopes for each one of these peaks. The slopes being the division, the ratio between the P1, the amplitude, slash the latency for each one of these peaks. Now, we divided our analysis into two parts. The primary analysis, the primary data set, was constituted by all patients who successfully completed LP opening pressure measurements and baseline non-invasive waveform assessment. For that, the parameters were compared between subjects according to all outcomes we studied here. For example, intracranial hypertension, abnormal chemocytology, abnormal LP test results. If a significant difference was found, the parameter accuracy was estimated with the area under the ROC curve. After that, we went for a univariate logistic regression, trying to see whether any of the parameters could predict any of the outcomes. And if any was found significant, then we would use them to build multivariate logistic regression models. And the coefficients of these models, if found significant, were used to produce scoring equations. We could calculate the accuracy of these scoring equations based on the area under the ROC curve too. For the secondary analysis, for the secondary data set, second part of our analysis, we used a secondary data set which was composed by all participants who successfully completed baseline and follow-up non-invasive assessments within each group. For that, we tried to assess the variations of the waveform morphology after the ICP raising and lowering maneuvers, comparing them before and after each one of these maneuvers. And the variation of these parameters were used for comparison between subjects to try to see if these variations could be associated with any of the outcomes we tested in the study. Again, if any significant difference was found, then parameter accuracy could be estimated with the area under the ROC curve. We conducted sensitivity analysis for each of our tests whenever possible. So when assessing the association between the parameters and the ICH, we would do a sub-analysis, including patients with abnormal CSF chemocytology, to see whether the association still persists, any found association could still persist and confirm our findings, and vice versa for CSF chemocytology among patients without intracranial hypertension. These are the tests that we used. The significance level was set at P-5%. Now, what about the results? Well, this is a data collection flowchart. We screened 189 patients. 176 patients were enrolled for the study. Unfortunately, 31 of them could not be included because it wasn't possible to obtain the opening pressure measurement in the lateral decubitus, mostly because they had to do the procedure in the sitting position due to technical difficulties, obesity, or any anatomical changes. 145 patients underwent baseline non-invasive assessment, and 15 of them we couldn't obtain an adequate waveform signal because they moved during the assessment. And we couldn't by protocol repeat the assessment, so they were excluded, and we got a final 130 patient sample, 71 for group L, 31 for group S, and 28 for group V. Our sample was generally balanced. The average age was 47. The 21% of our patients actually presented with intracranial hypertension, close to what we predicted. 50% of them abnormal CSF chemocytology, and 2/3 of them abnormal LP test results. The most common reason for referral for this study was chronic CNS infection, usually associated with HIV, inflammatory CNS diseases, 1/6 of our sample, and 1/10 of our sample idiopathic intracranial hypertension. What we found. For the intracranial hypertension, the ICH outcome, we found that there was an association, a significant association with an attenuation. It shows actually an attenuation of the percussion and dicrotic waves. As you can see here, P1 and S1 became diminished, and P3 and S3 also reduced. There was also a reduction in the area and area/total latencies. However, each of these parameters provided poor accuracy for detecting this outcome. In the secondary, the sensitivity analysis excluding individuals with CSF changes, P1, P3 area and area divided by total latency remained significant, and their accuracies became better, became acceptable in general. However, when we did the logistic regression, the only parameter which was able to significantly predict this outcome was the slope of the dicrotic peak, and therefore we couldn't do a multivariate analysis model. So for S3, a score under O.143 could predict this outcome with a high sensitivity but a low specificity, and because of the low specificity, a generally low or poor accuracy, consider the value of the area under the ROC curve. For the CSF chemocytology changes outcome, we found, and this is very original finding, for the first time, we found an association between the waveform and something that is not pressure. It's actually the changes of the CSF chemocytology, and we found that time-derived parameters instead of amplitude-related parameters were associated with that. So the latency to peak 1, the latency to peak 3, and the total latency of the waveform, because of the reduction of the latency to peak 1, there was an increase in the slope of peak 1, but overall the time-derived parameters decreased, providing, however, a poor accuracy for this outcome. In the sensitivity analysis, this time-derived parameters were still significant, and their accuracies became generally acceptable. We were able to see that these three parameters were also able to predict this outcome together with S1, the minimal point between P1 and P2, and latency to peak. So we used all these parameters to do a multivariate regression analysis, which provided a significant model that explained 16 to 22% of CSF change probability with a high sensitivity but a low specificity. The only variable that contributed significantly to this model was L1, and these were the coefficients from this model which we used to obtain this equation. A score over -5.0971 for this equation would provide a high sensitivity, but again, a low specificity and therefore low accuracy for diagnosing or detecting this condition, which is CSF changes. For the final outcome, we analyzed the abnormal LP test results, and we found that, again, time-related variables L1, L3, and total latencies were significantly associated with this outcome. They could also significantly predict this outcome. They were used for building a multivariate model, which was, again, significant, unexplained, and could explain 12 to 70% of abnormal LP test probability with a high sensitivity but a low specificity. No specific variable contributed significantly to this model, and these were the coefficients that we found and used to produce this equation. As all coefficients were negative, we multiplied that by -1, and this is the final equation that we got. A score lower than 5.0973 could provide a high sensitivity, but again, a low specificity with a moderate, poor to acceptable accuracy for detecting an abnormal, generally abnormal LP test result. For the second part of our analysis, we included 125 patients. 5 patients could not obtain this follow-up non-invasive waveform assessment, basically either because they couldn't perform the Valsalva maneuver or because they moved during the monitorization. For the largest group, lumbar puncture, which is an ICP lowering maneuver, we didn't find, from the statistic point of view, we didn't find significant differences in the parameters. There's just a prolongation, a significant prolongation of the total latency. but no variations of the parameters were associated with any of the outcomes. Although when excluding individuals with intracranial hypertension, larger variations of the L1 were associated with abnormal chemocytology, but again, provided poor accuracy, and we found that that was not clinically relevant. For the sitting position maneuver, on the other hand, as you can see here, there was a lot of changes in waveform morphology. It lost its three-peaked morphology and became like a mound form, mound-shaped with a single peak. It's hard to say which of the peaks disappeared, but two of them did. For a protocol analysis, would call that the first peak would always be called percussion peak. So for the analysis, it appears that the tidal and dicrotic peak disappear. So it's hard to say which one actually disappeared. The fact is that two of them disappeared and it lost their specific three-peaked waveform characteristics. But no, although these were very significant steep changes, no variations of the parameters were associated with any of the outcomes we tested, even after the sensitivity analysis. For the Valsalva maneuver, again, a lot of changes. There was an attenuation of the dicrotic and the tidal wave peaks. And because of the attenuation of the tidal peak with the preservation of the percussion peak, there was a very interesting reduction of the P2, P1 parameter was really unexpected because as this was an increase in hypertension in the intracranial pressure because of a controlled Valsalva, we would expect these parameters to rise, but it didn't. There was a lower variation of P2 amplitude in those with abnormal chemocytology with an adequate accuracy, but this finding did not persist after excluding participants with intracranial hypertension. So it wasn't very consistent, the results. These are the main findings. So ICH in our sample was associated with attenuated percussion and dicrotic peaks and smaller area and area/total latency. Only the S3 parameter was able to predict ICH with high sensitivity but a low specificity. Shorter time-related parameters were associated with CSF changes and an overall abnormal LP test, and we could use mostly these time-derived parameters to build scoring equations after obtaining significant multivariate logistic regression models. But both of them could identify these outcomes with high sensitivity, but again, low specificity. For the second part of our analysis, acutely raising ICP with the Valsalva maneuver led to attenuation on the tidal and dicrotic peaks. Acutely decreasing ICP with sitting position resulted in loss of the typical three-peaked morphology of the waveform, and a mild ICP reduction after LP resulted in prolonged total latency. Although these changes were not associated with any of the outcomes we studied. These are very interesting results. Firstly, because they diverge from what we have from earlier research. When we look at the acute brain injury cohorts, we see that the most promising parameter was P2 divided by P1, but this was mostly not associated with any of our outcomes. Why is that? Well, it's important to understand why the tidal wave is associated with intracranial hypertension in the previous acute brain injury series of patients. We know that this tidal peak is closely associated with cranospinal compliance. If we remember the lung-fit curve, and you have an increase in the volume, a pathological increase in the volume of the intracranial space, for example, a volume of a component of the intracranial space due to a brain edema or bleeding, at first you won't get a very high or very large change in the ICP because there are buffering mechanisms. There is an outflow of venous bloods and there's an outflow of CSF from the intracranial compartment, and the ICP will not change. However, and that's in this situation means that the tidal peak will become preserved. But as the volume keeps increasing, these buffering mechanisms will become depleted, and then you have the amplitude of the tidal peak will become dominant, and then P2 will become over P1 because there is a depletion of the cranospinal compliance mechanisms. This in the acute brain injury individual. However, we are not here in our sample. We're actually in the border zone. And in the border zone, this is uncharted territory. We don't know exactly what happens to the waveform in this part. Perhaps ours is the first study that actually attempted to characterize this with a lot of details. But what we found was that probably because the cranospinal compliance was not completely depleted, P2 did not change. But we found that P1 and P3 became reduced. Why is that? Well, it's possible that it has to do with long-term adaptation mechanisms. For example, we know from studies with chronic hydrocephalus that patients with chronic hydrocephalus and chronic hypertension, intracranial hypertension because of that, would have a decreased CSF production. That doesn't happen with the acute hydrocephalus or patients with Parkinson's disease. We know that CSF production is strongly related with the choroid plexus, and possibly if the choroid plexus, if CSF production is reduced, there's an hypothesis, probably the pulsation of the choroid plexus might be reduced. It's a possibility. So it may have to do with long-term adaptations. It also may have to do with underlying mechanisms of intracranial hypertension. For example, we know from studies with idiopathic ICH that although in these patients, the total, the pulsation of the arterial blood vessels is preserved, as you can see here, the full line, the pulsation of the internal venous vessels of the intracranial region are attenuated, as you can see here in the hashed line. And this has been attributed to the appearance of this stenosis between the transverse and sigmoid sinus. This has been debated in the literature if it is a consequence or if it is a cause of idiopathic intracranial hypertension, or both as a maladaptive mechanism, but whatever it is, it may explain an attenuated dicrotic peak. Again, mechanism-related process. The take-home message here is we cannot, at least from a waveform morphology point of view, we cannot say that acute intracranial hypertension is equal to chronic intracranial hypertension, because disease-related mechanisms and long-term adaptive mechanisms may be at play and may change how we interpret the changes of the waveform. What about the findings in the Valsalva maneuver? These are very intriguing, as we would expect, again, that P2, P1 would become higher because we increase intracranial pressure. But that did not happen. It actually became reduced, attenuated. Why is that? It's possible, again, that we are in the border zone and there is buffering mechanisms going on, and probably this would have attenuated the increase of the tidal peak, but again, it became reduced. How can you explain that? One explanation would have to do with the fact that cerebral hemodynamic changes during the Valsalva maneuver. Valsalva maneuver is not a homogeneous maneuver. It actually has 4 phases. We sampled the phase 1 and phase 2, and as phase 2 is the longest one, it's the most important for our study. In phase 1, there's the onset of straining leading to the intrathoracic pressure rise, and while the straining is maintained, in phase 2, there is a reduction of the venous return to the heart, thus reducing the venous outflow from the intracranial region, and explaining, for example, the attenuation of the dicrotic peak. And initially, there's a fall in the mean arterial blood pressure because there is a reduction of the cardiac output. This is represented here by a reduction of the velocity of the middle cerebral artery flow, which would lead, for example, to a reduction of the total volume, cerebral arterial blood volume of the individual. And that is closely related with the tidal peak and might explain why it became attenuated. What about the sitting position? It lost its typical 3-peaked waveform, as you can see here, which is very interesting. I like to say that this is very similar to what would have happened with the Valsalva maneuver if the trend kept going on. 2 peaks disappeared and it became just a mound-shaped waveform. What happened in here, like the opposites became quite similar at a certain point, probably because of different mechanisms. Again, it's a matter of cerebral hemodynamics in our view. As you can see here, this is a study looking at MRI flow studies among healthy individuals in the supine and sitting positions. As you can see, the total arterial flow is preserved, but the total venous flows becomes attenuated, resulting in a decreased pulsation of the venous system. This is because probably part of the flow stopped going through the internal jugular venous system and starts being also going through the cervical venous plexus, which reduces the pulsatility of the great venous vessels of the intracranial region. Also, because of gravity, there is a large outflow of blood and CSF volume from the intracranial region, and therefore you get a very great increase of intracranial compliancy, and the buffering mechanism becomes buffered, and we get an attenuation of any types of waves. That may explain a reduction, for example, of the tidal peak. Beyond ICP, one original finding of our study was that time-related parameters were associated with abnormal chemocytology. One simple explanation for that is that when we change CSF chemocytology, this CSF viscosity increases, and as for any type of mechanical waveform, these will propagate more rapidly. However, one other explanation now from a biological point of view, we know from studies with traumatic brain injury patients that a situation of hypocapnia due to tachypnea leading to vasoconstriction also leads to the reduction of peak appearance time, the latencies to P1 and P2. So vasoconstriction may reduce the peak appearance time. And we know that for example, the most common cause for referral for LP that would lead to abnormal chemocytology, CNS infection in our sample, that a lot of our the conditions that lead to chronic CNS infection in Brazil, neurotuberculosis, neurocryptococcosis, and even long-term HIV infections, we compose a large part of our sample are associated with vasculopathy and may explain this finding too. Whatever the biological underpinnings of our findings, these are very interesting findings. Once high sensitivity but low specificity is the trademark of a good screening method. And if we consider that in the United States yearly, we have 400,000 lumbar punctures amounting to almost $150 million due to healthcare costs. If we use our approach, especially equation 2, which is basically a screening for any type of relevant changes in the LP, and consider a diagnostic yield of 50%, over 50,000 non-diagnostic LP could be prevented yearly, leading to over $20 million economy in healthcare-related costs. But there are limitations. The most important one is the low specificity. Now, that could be explained by the fact that evidence has been showing us that other non-neurological nor neurosurgical nor CSF dynamic related parameters may influence the characteristics of the waveform when you use this method. For example, this paper published in 2024 shows that P2, P1 parameters becomes increased as time goes by, especially among the elderly, and that especially among women. We also know that baseline systemic conditions, for example, essential hypertension, might lead to higher P2, P1 parameters over almost 50% of our sample of individuals, and that dialysis chronic kidney disease subjects present with larger P2, P1 when compared to healthy and non-dialysis individuals and tend to normalize after hemodialysis. So systemic conditions might also lead to interference in the waveform. This study is original, but has limitations. We attempted to do a real-life sample, but that would lead to a heterogeneous sample with multiple underlying neurological conditions. It was single-center and does require external validation. The analysis within groups S and V, which is the smallest ones, especially group S with only 4 patients presenting with intracranial hypertension, may have been underpowered. The ICP gold standard measurement LP is not perfect, as I said before, and the study had a cross-sectional design, so we cannot infer the sensitivity of the method in identifying changes in the ICP or CSF chemocytology throughout time in the same individual. To end, these are the conclusions of our study. NIWA approach is able to detect ICH and or CSF chemocytology changes with high sensitivity but low specificity, supporting its possible role as a pre-LP screening test. Although it has low specificity, this may result from the influence of demographic and systemic conditions to be better explored in the future. Amplitude parameters seem to be more closely related with ICP, with latency variables with CSF chemocytology, and divergency with studies with acute brain injury settings may be due to the underlying disease mechanisms and long-term adaptations. The ICP raising maneuvers and lowering maneuvers do not improve NIWA accuracy. I'd like to take these few moments left to thank the people who contributed most for my education and for me being here today, especially my advisor, Dr. Daniel, Professor Manuel, who's who has been chief of the and founder of the Pain Center, Dr. Ida, who's here with us, who's chief of the headache group, and Dr. Lin, who's chief of the pain group at the Orthopedics Institute. Also, I'd like to acknowledge the efforts of the many collaborations who made this research possible, especially nurses Alessandra and Cynthia, who made a great effort in doing the data collection. Dr. Elio, who's responsible for the CSF lab for lending us the space and the patients to do our research. And also Brain for Care Brazil, who lended us a unit to do this research and provided training for that. Thank you very much, and I'll be answering queries anyway now from the board.
Congrats, Dr. Kubota. You present in this proper period your defense, your oral presentation. Now we start the discussion with this is defense committee. That this committee consists in Dr. Ricardo Iglesio. Dr. Ricardo Iglesio is a functional neurosurgery and brain tumor neurosurgery with expertise in general neurosurgery and ICP, intracranial pressure as well. He works in Institute of Cancer at our institution. Dr. Ida Fortini, she is a neurologist and a great professor in pain management in our institution as well. And Professor Xavier Moiser from France that will complete our team. My name is Wellison Paiva. I'm Associate Professor of Neurosurgery of our university, and I will be the president of this board, replacing Professor Siamp, that's not able to be here. In our board, we have a tradition that outside professor start the discussion. Then I would like to invite Professor Moiset to start your discussion with the PhD candidate.
Thank you, Mr. President, and thank you for the invitation to take part to this committee. That was a great pleasure for me to come last year in São Paulo for the CINDOR Congress. So I probably met some of you last year, and it's also a real pleasure to take part to this committee. The document sent by Gabriel Kubota was of really good quality, and the presentation today was excellent. But I still have some questions, comments. So my first comment is a general one, and you responded partially to this point in your defense. In conditions such as meningitis, intracranial pressure can rise over matters of hours. And in contrast, in idiopathic intracranial hypertension, this increase occurs gradually over weeks or even months. And you say that there can be adaptation that lead to different things that we can record. So how can you explain these adaptation parameters, and how can we look differently at the parameters in acute and chronic variation of ICP?
Professor, excuse me, we have some technical problems.
Oh, sorry. So,
pessoal da transmissão, consegue aumentar o volume?
The volume of your audio was not very clear. We're trying to correct here. Just 1 second.
To do something else. I have removed my microphone. Is that better now?
It's a bit better.
It's not.
Onde está o som saindo aqui? Can you repeat the question, please, Professor?
Yeah, first of all, that was compliments because your presentation was great.
Thank you.
The question was concerning the variation of intracranial pressure, even if it is acute or chronic, you cannot see exactly the same things. So how can you explain these differences? You've partially answered this question during the defense, but have you other points to explain for the differences between acute and chronic variation?
Jesus Christ. I understood that I explained part of why there is a difference between chronic intracranial hypertension findings and acute ones.
Yes.
As you said, it was related to the long-term adaptation mechanisms possibly, and because of disease-related underlying mechanisms. But there was a follow-up question which I didn't get.
That was the general question.
Oh, thank you. Yes, there was. And it's interesting because it's an exploratory study. It's meant to raise more questions and provide answers, but it gives an idea that perhaps the following research should be done within more homogeneous individuals among specific chronic intracranial hypertension conditions, such as idiopathic intracranial hypertension, to see specifically how it behaves for the diagnosis and throughout a follow-up. It will be very enticing to understand how it may change across different etiologies.
Have you taken into account the blood pressure during non-invasive monitoring? Do you have this parameter?
Unfortunately, we didn't take into account blood pressure. That we would need to have monitored it continuously with an intravenous intraarterial sensor. We didn't have that at the time, so we weren't able to do that. But one limitation of our study is an important one. I'm not sure if I mentioned that, but from much of our inferences regarding the underlying mechanisms of the waveform changes we found, it would be interesting if we had specific complementary data from hemodynamic studies, systemic hemodynamic measurements that could also add to our understanding of the changes. But unfortunately, we didn't do that. We worked with a more pragmatic approach, but it would certainly be a point to be a gap in knowledge to be approached in the future.
I'm sorry, you have been frozen for the last 10 seconds, but
okay. I
you
said that. Can you hear us?
Yes, that's okay.
Okay.
Now.
I said that unfortunately we didn't do that because we didn't have the sensor at the time. It would be interesting if we had more data from hemodynamics, systemic and cerebral hemodynamics, such as transcranial Doppler coupled with the analysis or neuroimaging studies that could help us understand the underlying mechanisms of the waveform changes. But we didn't do that, although this is an interesting gap to be approached in the future, certainly.
Thank you. I had also a question concerning the needles that were used. In your introduction, you say that post-dural puncture headache can occur in up to 40% of the patients. In your oral defense, you said 9% using adequate needle. Do you really have 40% of your patients with post-dural puncture headache?
Actually not. It might be an overstatement because some data go up to 40%. But actually, there was a paper in Lancet published, I think, 2 years ago. It was a large meta-analysis. It went under 1%, but it's not under 1%. I see more than 1%. I don't know if you see it in France too, but in any way, the thing is there is a large variation. And for this outcome, it's my belief that for many of the epidemiological studies, probably the way that you get the data may change how you perceive the frequency. Do you ask everyone if they have any mild headache after the procedure? Because if it's not severe, most of them will not come back and say it had. So for a retrospective analysis, this all may be underestimated. But it varies a lot in the literature. In the presentation, I chose to use a middle term because 40% is a lot too. I agree with you.
Thank you. And in your study, you have used 22 gauge quick needles, but currently it is recommended to use 25 gauge atraumatic needles. Why did you choose the 22 gauge needles?
It's what we have in the hospital.
Okay. So,
unfortunately.
because we have changed the needles in my hospital 10 or 15 years ago, and it has strongly decreased the risk of post-lumbar puncture headache. And there is no problem to monitor intracranial pressure. So
yeah,
I understand
In
the
Brazil,
technical
in some
problem.
centers, we do use 25 gauge needles, but it's a thing of cost, you know.
It's truly more costly, but if you avoid one patient with post-lumbar puncture headache, 3 days of hospitalization and blood patch, that can be very interesting still.
That is true. That is true.
In the introduction, you list different methods for measuring intracranial pressure, and there are 2 methods that you have not listed. It is possible to assess intracranial pressure in the measurement of venous sinus pressure. So during invasive venous pressure measurement, it has been demonstrated an excellent concordance between ICP measurements with LP and venous sinus pressure. Do you use also this method in Brazil?
No, most of the invasive methods for measuring intracranial pressure are usually either intraparenchymal or intraventricular sensors. So it's not commonly used. I'm not sure if it's used in terms of research here, but I'm not aware of any of it being frequently used in clinical practice. It's interesting to know from you, from Europe.
Yeah, if you want the publication that was proven by a French team last year and published, so I can
Great.
send it to you.
Please send me
Yeah.
to me afterwards.
Yeah, in my university, a system was developed to use distortion products of autoacoustic emissions. So this is a little device that is put in the ear, and you can measure the variation of the intracranial pressure. And one study has been published in patients followed for glioblastoma, and it is reliable to find an increase in intracranial pressure when you follow the patients. With your device, it can also be very interesting to see if in the same patients with a follow-up, you can see this sort of variation. Have you planned to do so?
One, I actually, it's marginal to what I have addressed in the final part of the thesis, but I truly believe that we could increase our accuracy by combining methods, and we can increase our knowledge of the mechanisms that leads to changes in each of the methods if we couple them together. So I think it's a very interesting proposal. If you have that in your institution, we would be happy to do a collaboration research and to maybe couple that be simultaneous measurement if it's possible. It would be interesting to see how the signal will change from one way to the other. I kind of mentioned one thing in the thesis. I think it's interesting because there was a new method for non-invasive assessment that was published really recently. It's called Archimedes. I think it's from a Swiss group, and it actually relies on the same principle as the one that we have here, but instead of having the sensor placed in the cranial surface, the skin, it's actually placed over the eyes with closed eyes. So it would be interesting, and the waveform is very similar. It would be interesting to see whether the barrier of eyes versus skull can change our observations. There might be pros and cons for each of the methods, of course, but it's something to be explored. And of course, coupling with other methods, transcranial Doppler or the autoacoustic emission. I read some of it, but I didn't actually, unfortunately, I didn't put it with more details in the thesis, but it's certainly very interesting to do. We would be very happy to do a collaboration research.
Yeah, a pleasure. I think that the key issue is that the sensitivity of your device is good, but not excellent. That makes it very useful for physiopathological work at the group level, but currently insufficient for confident individual clinical decisions. And if you can combine with other parameters and have a 100% negative predictive value, that would be very interesting. Even if you avoid LP only in 10 or 15% of the patients, you've shown the data for the US prevalence of LP. Avoiding 10% of the LPs would be great.
Certainly will, and I totally agree with you. Yes, we can increase the sensitivity and maybe the specificity also, and then you go for a different range of usefulness besides screening. But yes, it would be very, very usefulness, yes, to combine.
More than the sensitivity, I think the negative predictive value is the most important, to select the patient in which you are absolutely sure that there is nothing dangerous going inside.
Yes, that is true. I think one possibility, it's an hypothesis, but probably the flaw, the low specificity, in my opinion, it possibly has to do with different of these other elements that we don't know about. But if you use them in a single individual level to show how it varies throughout time for the same patient, it's a kind of an n=1 type of approach. We could isolate that, and possibly the clinical applicability will go beyond screening. But I do agree with you. It's another topic. Actually, I'm going out of the question, but I do agree with you. Combining may improve. I think for this type of conditions that may lead to LP, it would be very interesting if we had a like 99% sensitivity going for a very, very high negative predictive value. So that would be the best way out. But we could combine, and that is a way out, and that's certainly an interesting approach.
Now, in your study, you have defined chemocytological abnormalities with more than 4 cells. Have you tried with another threshold with more than 9 cells? And for protein concentration, you've taken 40 milligrams, but sometimes we use 50 milligrams. Have you assessed the robustness of your findings if you change these thresholds?
It's interesting. We haven't done that. It could be done because we have the data set and see if it changes our findings. We use commonly used thresholds in clinical practice at our lab. So this is the normality values for our population, and most laboratories in Brazil tend to use that. But it would be interesting to approach it from different thresholds. It might also be useful to do that. We had a choice for a threshold for ICP of 25. We know from the literature some authors prefer 20, but there is a gray zone between 20 and 25 that we see frequently. It's not necessarily pathological. Therefore, we chose 25 as more specific. There is, in fact, a pathology probably going on. But we could do an analysis going for 20 and see if it changes. I'm not sure if it will, but it certainly could be done. Yeah, the only thing is that the rate of changes, the proportion of patients with abnormalities would become decreased, and maybe our statistical power will be decreased too. But for CSF chemocytology, 50% of them had one abnormality, so it's possible that it wouldn't decrease too much. It's an interesting proposal. We can work with that.
For ICP, 25 is great. I don't think 20 will be useful. But for chemocytology, I think we can use it, because I don't know what you do if a patient has 6 white cells.
Yeah.
Do you really change your practice?
Depends on the hypothesis. But yeah, but it depends. It really depends on the setting, but I agree with you. Yes, it's again a gray zone. We have a lot of that into variations of CSF interpretation.
In the case of patients with blood in the CSF, with traumatic tap, how did you manage these results? Because they have more white blood cells, but it's not a meningitis. It's only due to the red cells.
This is a very important insight. We didn't exclude them. There weren't, from what I saw, looking at the database, there wasn't a lot of traumatic lumbar punctures. The final analysis we used, it's part of our routine to assess the CSF after at least 2 or 3 tubes. So that decreases the possibility of that happening, but it's possibly it's a limitation of our study. this is very interesting. It should be mentioned, including in a final publication. Thank you very much.
I think it's important to say how you manage, and if it's only 2 or 3 patients, that is not a problem. But if you have 10% of the patients with more than 500 blood red cells, that would be different.
Yes, certainly. Yes, it's an important addition. We will certainly take a closer look at the data and see if there's. I don't believe so. I registered for all the LP results, and I don't remember seeing. I don't remember having one of them, but it's important, of course.
I had another question concerning the sample size calculation. You write in the methods that 130 patients were required and that you planned an allocation ratio of 2 to 1 to 1. In the results section, you really have 130 patients, but the planned ratio is not as expected. You have 71, 31, 28. So it gives the impression that the sample size calculation have been performed retrospectively. Was it the case? Is it just a convenient sample and a calculation made afterwards?
No, it was actually before. We have a document for that. The sample size was estimated before. The idea was that we actually wanted at least 60 patients in the most important groups, and we found that the most important group for comparison would be before and post LP analysis, because it was the one that were more certain that we could do it and we could control it, because we had an opening pressure and a closing pressure. So we wanted to guarantee at least 60 in this group. As we wanted 3 groups, we thought of 60, 30, 30, but there was 10 patients. We considered a loss of around up to 10% of patients. That's why it ended up at 130.
Okay, but you know immediately when you are doing the LP and the non-invasive assessment that you will be able to use the data. So why did you go above 60 in the largest group if 60 was enough?
We considered that we considered the possibility of losses in the measurements, but that is why we went for more. We could have stopped the trial, the study, once we reached 120, because well, we didn't need the other 10 because it was a safety margin. But again, it was a convenient sample. We didn't know exactly if it would be enough, and we supposed so by our estimation. So if we estimated for 130 in the initial idea, that is the initial idea, then we went for 130. That's why we went for up to the end. But I hope that explains this appearance association.
It is a minor point, but it's important to explain it properly for the reviewers in the final publication.
Great, I'll do so.
With that.
Thank you.
I had also one question concerning table 1 with the BMI. We just have the mean for the BMI, and I think it would be interesting to have also the proportion of patients with BMI above 25 or above 30. And if the groups are large enough to have sub-analysis for these subgroups. I don't know how many patients were above 25 or above 30.
Yeah, I didn't do this analysis, but noted. I will do. I think it truly expresses, it gives you a better feel of the sample when you separate. We could do that by typical ranges, lower than 20, 20, 25, 25, 30, over 30, 35, over 35. But thank you for the suggestion.
Thanks. And in the largest group, you have non-invasive assessment before and after LP, and which was the median time between the LP and the measure that was done afterwards. because CSF production is important and the volume can be restored very quickly. So if it is 2 hours later, that's not the same as if it is 10 minutes later.
It was actually, we didn't specifically measure that, but it was all for all patients less than 20 minutes later. We completed the LP, and just after that, we did the measurements. As soon as the patient was calm and lying down and accepted the procedure, we could do that. So I think CSF production wasn't a problem here, but it's important to mention that in the methods. I'll stress that.
You should write it because 20 minutes is perfect, but it should be mentioned. And was there a control during the baseline non-invasive measurement to be sure that the patient was not performing a Valsalva maneuver inadvertently? Or how did you control
During the
that?
LP measurement, yes?
Yes, during the first LP measurement.
The LP measurement was done as our routine. Measurement was done when we felt the patient was calm and not anxious. We actually, it wasn't published because it's difficult to say that, difficult to report that, but we tend to measure the frequency in which they appear anxious during the procedure. It's something that we do, and it's something that is reported in some of the final results of our LP procedures. But I didn't report that I have this data, but I didn't report that. It's difficult to actually report this proportion. 40% were anxious during the puncture. It's difficult. It's subjective, right? But we measured when we felt the patient was calm, and we instructed not to move during the measurement or to cough during the measurement. But it's difficult to control that for. The measurement was done according to routine. And it's, of course, again, our gold standard is not quite precise. LP is not perfect for measuring. There may be interferences, and it's a limitation of the available methodology in that sense.
For some patients with spontaneous intracranial hypertension or idiopathic intracranial hypertension, we have to measure for several hours to see the variation in ICP. Is it possible to wear the device continuously for hours in your case?
Yes, it certainly is. And I didn't have the time I didn't want to blow up the time too much during the presentation, but one thing that I wanted to say, but I didn't have the time to, is research perspectives. And one of them, which I find very interesting for this device, is working with ICP circadian rhythm. There was an interesting publication, I think 4 years ago, looking at the ICP circadian rhythm with TBI patients, traumatic brain injury patients, and it appears that when you have certain abnormalities of this circadian rhythm are strongly associated or correlated with prognosis. It would be very interesting to do something like that for patients for outpatient individuals. One thing that I thought of, but we weren't able to do that so far, but I still think it would be interesting, is to couple it with polysomnography, which is an examination that the patient would have to stay at least per night through the night. And we could start the monitorization a bit earlier, or do that during video EEG. But okay, of course, you'd have patients with epilepsy, so it might be a bias, but it's a way to do that without requiring the patient to be there 24 hours because of the research. But coupling with polysomnography is something that is it would be very interesting. See how it changes, if obesity can change ICP. That'd be interesting with the pool of research, the bulk of research with the lymphatic systems. Maybe there would be findings that could be associated with long-term dementia, for example. It's a possibility. But again, it's just ideas, but it's certainly something that crosses my mind. If you have the autoacoustic device that you have there can do a continuous monitoring, or is it a point in time?
We can also do continuous monitoring. That was done in ICU to correlate with invasive pressure. So we can have it for hours and even for days.
We could couple with that and do it a pulmonary sonography. It's a lot of monitoring device for a patient, but it would be very interesting to see the results.
Yeah. So I don't have any further questions. Thank you very much for the quality of your response, and congratulations for the quality of your work.
Thank you very much, Professor Xavier. It's an honor to have you with us today and to have your insights. Thank you very much.
Thank you, Professor. Are you satisfied with the ability of the candidate answering your questions?
Excuse me?
Yeah. Are you satisfied with the
Yeah,
answer
perfectly satisfied. Great quality of answers.
Then we are continuing with this defense, and now I will invite Dr. Iglesio to do his considerations.
Oh, thank you, Professor Paiva. First of all, good morning. Thank you, Gabriel, and thank you to Professor Ciampi for the invitation. It's a pleasure to be here today. I think I was at your qualification exam, so I will be brief and some small comments regarding the entire study. I think it's a very good study because we know how hard it is to accumulate that number of patients, to gather all those patients. Specifically, over 150 patients were screened. So congratulations to you and all the team about the effort put into this study. First of all, I would like to comment some differences between the groups. As Professor Moise has mentioned, hypertension was one topic that could influence the result of the final waveform of the study. And I think in the Valsalva group, there were a little bit, a slightly larger amount of patients with hypertension. Also, I think age can be a variable that can be a confounding variable between patients, because we know that the complacency of the skull will vary. It tends to get smaller when people get old. So, and about the CSF volume, or the total CSF volume extracted from the patient, because we had a slightly large variability from 3 to 70 milliliters, and I think it can impact on the results of the first group, the group that you measure the waveform after the extraction of the CSF or the lumbar puncture. So I would like you to comment how you mitigate those imbalances, perhaps between the samples, and if it will be possible to account for those variables in your logistic regression or your multivariate analysis.
Thank you for the commentary. Actually, the study was not randomized. We didn't randomize, so we didn't expect that baseline characteristics would be similar between individuals. As the study didn't intend to compare between groups, there was no comparison done. We wouldn't be so worried that that would influence our results. Actually, we thought that it would be actually a good thing that in group L, and also it was not blinded. There was no intervention as an all observational study. So we knew who were the patients for group L, and there was a trend for us to getting a bit more volume from these patients to actually see the difference. But although I agree, these differences may play a role when we compare the results. As the secondary analysis were done within groups, I don't think it changes a lot. how we perceive or how the final conclusions. It is possible that eventually baseline demographics would give underlying different behavior, and we couldn't actually generalize findings from a single group to the general sample. But as there was no direct comparisons, we didn't find that to be to lead to significant bias, and that will lead to need to correction. As we did an exploratory study, we also we were a bit more less strict in the statistical methodology we chose. For example, we didn't do Monfehoni correction, which could inflate type 1 error, but as it is an exploratory study, that would also be too strict for us to capture any signal from that. So I think that with it, our impression.
Okay, good. Perhaps on a future study, it will be interesting to account for those variables. I think in the model, the final model, to compensate, especially age-related variables that can alter the complacency of the score and perhaps change the final result of the model.
It's a very important input. We didn't have the data from the study that was published last year when we started the study. Actually, data collection finished before they published the data from healthy individuals that showed us that gender and age may change P2P1 at least. So it would be interesting to account for these variables and also hypertension in future studies, especially when we start comparing between groups, which will be the next step. So it's interesting to do that, of course.
Okay. Another thing I would like to comment, I didn't see it on the manuscript, but what kind of algorithm was used to extract the waveform? Because you've mentioned that the waveforms were extracted and they were calculated a confidence interval, and you ignored the waveforms that didn't that were over or under that interval. I think it would be interesting just to cite the kind of algorithm, because it may come to different waveforms, patterns based on the algorithm that was used. Perhaps it's a proprietary algorithm of the company that provided the equipment. I don't know.
It is a proprietary algorithm. We didn't have access to the algorithm itself, but we should mention it. Of course, the original paper that used the algorithm for the first time. Thank you very much. It's important, an important insight. Thank you.
Okay. Another question, it will be regarding the calibration of the sensor, because you don't have an absolute value of the waveform. You express the values in millivolts, which are calculated based on the sensor calibration. You have gathered over 150 patients over probably a long time span. So it was always the same equipment that was used, and any kind of calibration was done to the sensor throughout the process, or the equipment company provided some kind of assurance that the calibration would stay enough during that time.
It's an important input. We use the same device for all patients. There was the company told us that there's no need for calibration throughout at least the time that we conducted the study. So we didn't keep calibrating throughout time. I think even for studies that we have previously published with the acute brain injury setting, calibration was not at least mentioned in the methodology. But it's an interesting point. I'll have to talk to them, but I think it's been used in some ICUs. It's been incorporated recently in the hospital, and calibration is not something that is usually done for the device. I'm not sure. It would be interesting for the company to have this data to see, of course, the confidence of what they provide from the data. But There's
Yeah.
no actually information about that.
Because we know that those sensors tend to drift away along the time. For the
That's true.
invasive monitoring, we have a kind of some numbers that we thought as being safe to use the device before the error starts to be too big. Since we have a very sensitive sensor and there is the rubber band around the head that also can stretch over time. It will be interesting to talk to the company and address that in future publications.
We could do. I'm not sure if it would answer this worry, this question, but we could do an analysis comparing the beginning of the patients that we done before and afterwards. If there is a large change in the findings. Of course, even if it was, that doesn't necessarily mean it has to do with the calibration. But it's something that we could explore. But yes, it has. We will discuss that with the company.
Okay. On your flowchart diagram regarding the inclusion of the patients, you've mentioned that around 10 to 12% of the patients were not able to be tested with the device or underwent the measurement of the waveform. Thinking about that device being used as a triage or a screening test would be, I think, a slightly larger percent of patients that would be able to underwent this diagnostic test. What do you think about that, and what are the future implications for the incorporating this device in the clinical practice?
Very, very good question. Yes, 145 patients went for baseline non-invasive waveform assessment, and 130, so 15 of them couldn't complete that. I think the failure rate, let's say that, was a bit overinflated because by protocol, we couldn't repeat the assessment. So if in 2 minutes the patient started talking, we would stop and we wouldn't do again. That was our protocol. So, however, in clinical practice, if in 1 or 2 minutes he starts talking, you would say you could remain quiet a bit more and start again. So probably it would be reduced for supine. But we, from our pilot studies and from our experience, using during the Valsalva maneuver and particularly during the sitting up, upright sitting position, it may be challenging. The patient has to be very well instructed because there is a trend for movement even in a sitting position. And the failure rate, although it wasn't great, it wasn't large from what we got, it's something that may limit its feasibility. But for the supine, it's possible that if you instruct the patient, if you stop and start again, it's not a problem. We also only included patients who completed 5-minute monitorization, but it's possible with lower times, 3 minutes, 4 minutes, you also get a very good result. I think it's something that to think of. But it may have been overinflated by a stricter research protocol study, but something that should be considered.
Okay, perfect. You found that amplitude-related variables were more associated with differences in ICP, while time-related variables were more related to chemocytological changes in the CSF. You explained briefly during the presentation, what are your impressions about that? How do you view those two findings together? Why do you think the ICP is more related to amplitude variables and chemocytology changes are related to time-related variables?
Yeah. Well, we know a lot of how amplitude parameters might be related to ICP and CSF dynamics, because this is the finding that has been explored before and more investigated previously in the literature. But the association with CSF chemocytology is something new. It's actually our finding. It hasn't been explored before in the literature. It should be, of course, confirmed by external validation, but my guess it is because the changes in the amplitude would have to do with how we perceive the variation of the signal throughout the time, and the variation of the signal pulsation, blood vessel pulsation, and CSF dynamics, while when we look at the propagation of the signal, the speed of propagation of the signal, I think it has to do more with the media throughout which the waveform propagates. So although I showed you a study that shows that vasoconstriction will lead to a reduced peak appearance time, I actually believe that probably the element that plays a stronger role in explaining changes in the peak appearance time, the latencies, have to do with the media in which the waveform will propagate, the viscosity. Didn't have the time, but there's no clinical data to support this. It's an hypothesis. It's largely an hypothesis. There was a very interesting study published this year looking at mathematical modeling to predict the waveform characteristics. So they compared invasive measurements with the predictive waveform, predicted waveform. And they found that if you take into account viscoelasticity elements, the predicted waveform will behave much closer to what we actually measure than if you only take into account elasticity. So I actually believe it's a thing of the media. That is why perhaps coupling with other non-invasive methods that may get the signal of the waveform may give you an insight of how media of propagation may interfere in our signal. But I think I would go for that, for an hypothesis.
Another possibility is that since the waveform measured is derived from the cardiac cycle, and the patients with chemocytological alterations may be, as you showed, most of them due to infectious disease. If the patient has a slightly larger heart rate compared to the other patients, those time spans will be shorter also. So I think perhaps in future studies would be interesting to compare with the cardiac cycle or their heart rate, or use this as a parameter, because tachycardia would impact those time variables exactly as you showed, and probably due to infection or systemic variables.
It is very important. Yes, there is a new version of the device that actually couples it with the the oximeter, and it's something, it couples that so you have both informations. But when we started the study, we used the original device that didn't have that. Yes, it goes in the lines of getting more information to understand the physiopathology of the changes. But you're right, completely right. It's something that it should be done in future studies.
Okay. Since you have a large sample, I would say 150 patients, it will be interesting to see a leave one out or k-fold analysis since you developed the logistic regression models. I think the choice to use those models were great, because they tend to model all the variables at your disposal within the results that you get. But perhaps if you then leave one out, or five-fold test where you leave 20% of your sample out, and you apply your model, and the remaining 80% train the model, and then test it on the 20% that you left out, and do that repeatedly, it will show us the robustness of the models that you developed to show the results that you're saying. Because as you mentioned, they are borderline results regarding the accuracy of the method. So perhaps for future studies, or I don't know if you have some other statistical approach in mind.
We're actually exploring the possibility of doing a second publication, working together with Aalborg, with a team of data scientists there to develop an algorithm to do that. But it's an interesting suggestion as an interesting approach. It could be done. I think the sample, although it's 130 patients to do that, maybe it's a bit more to going for 200. Then we have more data to do something like that. But I think it's a very interesting suggestion. Thank you very much. But we are approaching the idea from algorithm. I think it's at the moment of the literature to approach that. There was an interesting study published this year. It was actually a sponsored study, so yes, you have to be a bit cautious in reading that. But was published in a paper. Those papers, those journals that are associated with Nature Publishing Group. And basically, they used a method in the acute brain injury cohorts, and they found that they developed a machine learning algorithm that could actually give you the value of the ICP when compared. And there was a moderate correlation with what was actually measured. It's a promising way out. I think it's an avenue to be explored, especially because this gives us the information that goes beyond working with parameters. We are actually analyzing the morphology, the view, the visual information of the waveform. But yes, it's something that should be explored. And thank you for the suggestion. I hadn't thought of using this approach, but it's very sound.
Yeah, just to show us the robustness of the model, I think would be interesting. And one last thing regarding your comments of that method being used as a screening technology or device to reduce costs and implementation in clinical practice. You provided the a priori probabilities of the patients have a disease in your population. So overall, 63% of the patients had actually an altered result in the CSF exam. 21% for ICH and almost 50% for chemocytological alterations. If you use the data you provided regarding sensibility and specificity and do a simple Bayesian calculation, your improvement of diagnosing the patient is marginal, because you go from 63 to almost 70% if the test came positive. But if the test came negative, you can say you still miss out 30% of the patients that actually has some kind of disease. So I think we should be cautious when you say that it can be used as a screening test, because in this context you cannot exclude totally the CSF puncture or other tests that you perform anyway.
It's an important consideration, yes, because it's one thing, as Professor Xavier said, it's one thing to say to talk about a sensitivity, which is a property of the instrument, and negative predictive value, which will depend on the setting you have. So if you have a setting that has a 30% chance of having a positive diagnosis, then with 96% sensitivity, it's kind of okay. But in our, which is a tertiary care hospital, and with a high probability of having some abnormality, 60%, if you consider one of them, then yes, that wouldn't be enough. So yes, it would depend in the setting. So you to have, and yes, it should, depending if there is a high probability of chance of becoming something abnormal, then we would need a better sense, a more sensitive screening device to do that, or coupling with others to provide better safety. But if it was a very high probability, I think I wouldn't do the screening. I would go for the final examination too. But yes, it's something when we did we are submitting the paper for European Journal of Neurology, we are adapting the manuscript. And because of this, I didn't include that in the thesis, but maybe I should. Our comment is that it could be an interesting screening device in low to moderate pretest probabilities, but not in high pretest probabilities. You have to have 99.9% for that, especially when you're talking about neurological conditions and neurosurgical conditions.
Yeah, perfect. Oh, thank you very much. I'm very
Thank you very
satisfied.
much for being here.
Thanks.
Now the Finnish board member, Dr. Ida Fortini, do her consideration.
Well, good morning for you all. I am grateful for the honor of being invited to join this panel alongside such distinguished colleagues. And I had the privilege of knowing Gabriel for many years, that he is a highly competent, diligent, serious, and dedicated physician, qualities that are evident both in his clinical work and in the thesis he presented for our review. He delivers his work in English, fluent, impeccable English, unlike my own, which may not reach the same standards. And for that, I offer my apologies. As a professional who frequently treat patients with idiopathic intracoronary hypertension, I am keenly aware of the need of a simple, safe, and reliable instrument to assess the degree of hypertension and monitor its change non-invasively. Therefore, when proposing a device intended to obtain diagnostic information, it's essential to understand precisely what the instrument measures, what data it provides, how these results should be interpreted, and the degree of reliability they offer. Only with this clarity can we determine whether the method can be appropriately used for its intended purpose. Naturally, having an instantaneous and simple measure of ICP would be highly valuable. In this sense, it's very important that the exploratory observational studies sought to determine the accuracy and feasibility of detecting intracranial hypertension. In outpatients, referred for cerebral fluids examination, using this device for assessment of the waveform. It's data that is lacking in the literature and very in need. The primary study analysis object is clearly described, and as well as secondary analysis. The introduction section is concise but adequate, and moving to the study design, page 5, the study well described and meticulous, leaving no room for doubt about the measurements that were performed or under which convinced. The section dedicated to the eligibility criteria, you included additional exclusion criteria in the supplementary material. Why not incorporate them into this section? Presenting all quick criteria here would make the test clear and reduce the effort required by readers of the final article. And also, I would like to know, why did you include patients that had previous GVP or DLP? Don't you think this would influence results?
Actually, thank you for the insights. I'll consider that for improving readability. I think it's a balance between presenting a very long test and being more straightforward, but missing some information, and maybe the reader will need to move through the paper. But it's something to consider. Thank you. And for the why did we include patients with LP? Well, we didn't think it is. It was. At first, we didn't think it would be a problem because measurements would come essentially. It wouldn't interfere in the measurement, and we had previous publications using the method in shunted patients, so it's possible. It would be possible to do that when you actually see the papers published comparing the invasive methods with the non-invasive. The invasive method is essentially an EVP, right? It's you had a sensor in intraventricular, so we didn't think it would actually change. But looking at the data now, coming back, the waveform is so sensible to so many things. Maybe a different analysis would apply to see if it behaves different. It's a very good insight. It should be considered. Although most of our sample, it's a very small minority of our sample that actually had any shunting procedures.
So you had 12 patients.
Yeah, it's 10%.
EVP and 2 with LDP.
Yes. The whole proportion is rather small, but I think it's something to be considered to better understand how it would change. Yeah. Thank you.
In page 6, lumbar puncture, I know the volumes retrieved from CSF analysis is small, but I wondered whether the volume withdrawal was consistent across cases and whether this variable could interfere with the waveform assessment.
Actually, the extraction, the volume would only interfere when we look at the group L and not for the conclusions of the primary analysis. It is, I think it's possible that it would interfere if you had when you have, according to the final opening pressure, a closing pressure rather than just the volume itself, but something to be considered. We actually, again, try to do a very pragmatic approach. So we didn't limit the volume. It was according to practice. And the largest volumes that you can see here are actually outliers from subjects that went for the normal pressure hydrocephalus step test. Yes. Then that's why the volume became large, but it's a small minority that went for like 70 mLs, as you can see here. This is the range of the variations. But I think for that, you could do an analysis saying, according to the final pressure, if there is an association with any parameters. It's something we didn't do that. Something that could be done to better explore this variation. It could be done. 70 patients is possible. It's interesting insight. We could do that. Thank you.
When analyzed item 321, page 10, when subjects with a normal chemocytology were excluded, just the amplitude parameter P1 and P3 and the area parameters and ATL remain significant. The test states that the accuracy became generally accepted. Supplemental material, page 8, However, the relevant information actually appears on page 10, table S2, as the supplementary material.
Thank you for your correction. I'll do that at page.
There are others of the same. It's indeed interesting to note how chemofluid cytology influenced waveform characteristics, specifically the shortening of the latencies with larger S1 components. In the session where you stated, based on the respective B of included variables, the following scoring equation was created, but the equation itself is missing from the manuscript. I've seen it in the presentation, but it's not on the manuscript and also not in the supplementary material.
I have it in my final documents, but I can send you again. I'm not sure what happened.
Moving to the discussion, you obtained very interesting results. You observed alterations in P1 and P3 in patients with ICH. Notably, you demonstrated for the first time that ICP waveform morphology is independently associated with changes CSF cytology, specifically casing a reduction in waveform lattice, but not amplitude. Your hypothesis regarding increased viscosity seems very reasonable. And regardless of the underlying biological abnormalities, the waveform assessment demonstrated high sensitivity, 96.2% for predicting abnormalities in LP research. And this is a very important finding in my understanding. And I agree with the implications before performing lumbar picture. For high-risk patients, you should take that into consideration. If the waveform assessment is normal, maybe you could not perform the procedure if there is a high risk involved. And this is a very good thing, I think. Now, and also for older patients, the limitations of the study, you stated them very clearly. I agree with the heterogeneous sample, monocentric study. But I think the most important limitation is the small groups, subgroups sizes, which limited the statistical power, as seen particularly in group S. In the conclusion, the waveform was shown to detect not only intracranial hypertension, but abnormalities in cerebral spinal fluid capsulometry with high sensibility, although with low sensibility. The adaptive changes that occur over time in patients with intracranial hypertension may warrant further investigations. Even though the primary objective yielded a negative result, it remains highly important and clinically relevant to understand precisely what's being measured and the type of information this assessment can provide. And I congratulate you on your work.
Thank you very much, Dr. Ida. Happy to have you with us.
Dr. Kubota, in tradition, it's not a law for me as president of this committee to do question for you, but I will break some rules.
Okay.
And I will do two questions. The first question is, you are a neurologist working with pain, chronic pain and neuropathic pain patients. And why this topic? This is the first question. And second question is, today is not the finish of your walking in academic career. Today is the first day of your academic career with a PhD, if this committee allow your award. But today is the first day. And what are your plans for tomorrow?
Very good. For the first question, actually, I was talking with Daniel, who was my advisor. I understand the PhD is not the work of my life. It's a work that leads, it's a period for scientific or researcher education. I use this study, I think it's, as for a study, I actually chose it because of the methodology, not actually because of the topic. I think it needs a lot of research. I don't know if I got that, but I think that you have to have a lot of creativity and maturity to do an exploratory study that is actually well conducted, because there are a lot of choices from statistics to how you're going to select your sample that leads to a lot of discussion. When you do a trial, it's much more stricter. So I think I chose that because it's marginal with headache, actually. It's very, in my opinion, relevant. I think it's interesting to have a Brazilian technology. We have so very a tradition to import or reproduce data from outside. I think conducting research with Brazilian technology should be emphasized. So it was an honor to do that in my PhD, but mostly because I think the idea to have the data and the ability to explore the data, I think it led, it gave me more opportunities to grow as a researcher than I would have with a very strict methodology, such as a clinical trial. Although it would be easier to publish sometimes, but I think it's something that more in that sense. And also, as I suggested in thesis, I took this period to do more than just one research. The idea is to grow as a researcher, and that within a close advisor to do that within a series of different methodologies and different types of questions. I think I tried to accomplish that. I hope I did. But that leads to the next question, what to do next. As you said, and I totally agree with you, I don't take the PhD as the final part of my career, but just the beginning. I intend to keep walking close to the academia and to do collaboration research. I actually am starting a few lines for next year and help others to achieve the PhD graduation. I think it's something that I like and I feel good doing. It's something that I see myself doing in the future. So the next steps would keep on doing research. I was, a few months ago, I was already discussing what would be my post-PhD project. Now I want to do with headache specifically and neuromodulation. But again, I think I learned a lot. I want to learn more from people like you, Professor, and the members of the examination board, colleagues from France. And yeah, that's it's the start of a long journey.
Now, I would like ask the audience to leave this auditorium for a few minutes because we need to discuss about the approve or not